Good morning, Facebook. I am Megan Rogers, and I am joined by my co-hostess, Susan Spilly, and we are back in Indiana from our wild adventure to the NCOA conference last week. And we are going to talk about HIV and AIDS advances and treatments this morning. And Susan, I'm going to pass it over to you because I believe you have a special guest with you today.
I do, and she is with me, as in sitting right next to me. We're so excited that Dr. Christine could join us this morning. She is a nurse practitioner at Eskenazi Health in the infectious disease clinics. So she's going to share with us all kinds of information about AIDS and HIV care and a little bit about how Medicare covers those. So thank you, Dr. Chris, for being with us. We appreciate your sacrificing your day off.
It's good to be here. Thank you for having me. I'm focusing some of this on, since we're talking about Medicare, HIV and the aging. And they consider aging 50 and over.
Oh, ouch.
I know. That's what I said. But no, they look at it as 50 and over. Also, our population is aging, as well as the caregivers are also aging. About 51% of the people living with HIV are in the US are over the age of 50. When you look globally, persons over the age of 50 have increased from 5.4 million in 2015 to 8.1 million in 2020. A lot of this is long-term survivors or people that were diagnosed when they were younger are now getting older. And there is some increase in new diagnoses in the over 50 population as well. A lot of our and medications now, especially since 1996, has actually been the reason for this increase in longevity. It's really helped people to live a lot longer. And if we can get them started on treatment early to pretty much have a normal life expectancy. There's about 40,000 new HIV diagnoses a year. Unfortunately, that number doesn't change much. And about 17% of those are age 60 and older. Unfortunately, it's more women than men that they are finding at that age. It's interesting because the CDC has guidelines for universal testing, and I find it interesting that their ages are 13 to 64. Why they stop at 64, I don't know, but they stop at 64. The other thing that a lot of statistics that are coming out now, there's a little bit of discrepancy in the numbers. During COVID in 2020, there wasn't a lot of data. There wasn't a lot of testing. Unfortunately, because COVID has the same symptoms as HIV, nobody looked at HIV testing in some of these people that were going to the emergency room, only COVID testing. Older people are less likely to be tested. They have signs and symptoms that are mistaken for the aches and pains of aging or the flu. Many feel ashamed or afraid to be tested. And many don't feel that, when I say many, this is providers don't feel that older people have sex. So why are they at risk? I have a funny story. One of the organizations that I work with, the Association of Nurses in AIDS Care, they were talking about in Florida, they were having an uptick in elderly that were being positive. And what had happened was at the first of the month, there was a sex worker that would literally go to the senior housing and would literally go from apartment to apartment to apartment to apartment. And so they put a stop to that, but that was their rise in that. And there are a lot of elderly that still want Viagra. So if they're taking Viagra, they're obviously having sex. The other thing is older individuals, older positive individuals actually have their own set of issues. a lot of them, they have additional health problems. They have diabetes, hypertension, liver disease, and HIV can kind of make some of those worse. Some of those can make HIV worse. So it's a real, in working with those patients, you kind of really have to keep trying to get everything under control. There's also an increase in stigma of being HIV positive when you're older, and there's more isolation and loneliness. There aren't a lot of support groups for the elderly, so when they go to the younger ones, they don't feel comfortable. And it's not a lot of my older clients that have been positive for years will say, you know, these younger people just don't get it. They didn't lose friends like we did. And so they don't understand. And and I find that very true. I'd say about half my clients are over the age of 50. And we actually have an 80-year-old in our clinic. So they're still going strong. They have found, though, that those over 60 are more likely to take their medications. Therefore, they're able to keep their viral loads under control, which is one of the things that we want to do. There's a push for make a cure and to basically eradicate HIV. And that's through early diagnosis, getting them into treatment right away and getting their viral load down, because if they have a viral load of less than 200, they can't spread HIV. So there's a lot of things that are going on with that. We also have the Ryan White Healthcare Program. It's been around since 1992. So it's 31 years old. I know our clinic's been around for 31 years. And it actually provides services to our patients with HIV. They have to be 300% of poverty in order to get services. They also have to be in care coordination. So a lot of these services are provided either through a care coordination site, or there are some Ryan White clinics throughout the state, and they have the services, both medical services and psychosocial services. Some of the things that they provide dental, eye. They also provide transportation. For our patients that are on Medicare, they can also qualify for what they call MDAP, or Medicare Drug Assistance Program. And so it pays the copays of their medications, which is very helpful and actually can be better than some of the others, because our medications are very expensive.
We did have a question that was texted in or commented in on our Facebook page. What is the average cost of medication to treat HIV?
I was just getting there. The average cost. So now there are some generics out there. The problem is the generics that are out there are older medications. So that required more pills per day, more side effects. Now we have a lot of what we call single tablet regimens. So there's actually a whole regimen within one tablet. So you usually have 3 drugs in one tablet. And our most common one is Biktarvy, and it runs about $10,000 a month. We now have an injectable treatment that's every 2 months. So they come in every 2 months and they get an injection. And that's $30,000 per visit. So they're still very expensive, but and a lot of insurance companies are really not covering HIV medications anymore, or their deductibles are really, really high. So fortunately, because we're not using the generics, the drug companies have really stepped up, and they have an excellent copay assistance program to where the patient may have to only pay $5, if that much. We just have to get them signed up. So that's it. They're still very expensive. You could do it cheaper with the generics. We're doing a lot of pre-exposure prophylaxis. So that's people who are at high risk. Sometimes it's a partner of a patient, or somebody else that would be at higher risk. They come in, we give them a medication called Truvada. which is generic now. And they take 1 pill a day, and it can actually decrease the transmission of HIV to those that are negative. So, and that's fairly inexpensive because Truvada is generic at this point in time.
Well, I see those commercials for Biktarvy. Now I'm really going to be paying attention because, oh my goodness, $10,000. And, we see working with Medicare beneficiaries and the cost of their drugs with helping them look at Part D plans, that there are a lot of 10,000 plus medications for certain health conditions. So, and the one that's the 30,000 every other month that's injected in clinic, that would probably come under Part B of Medicare, and they would have the 20% copay.
So there is a facilities fee that comes along with that. So Medicare Part B would probably pay them a facilities fee. But I think it still falls under the drug plans. But we've had the thing that Medicare Part D, when it rolled out back whenever
2006,
one of the things that they put in there is that all HIV medications will be covered. And so that's one nice thing about Medicare is they have to cover the HIV medications for our clients. And I think that's what's added to the longevity of a lot of these people. The thing is back in the day. So I'm going to kind of clarify. I've been doing this since 1986 when I was a nurse. And I've actually been in my current clinic for it'll be 25 years in January. So I've been doing HIV care for a long, long time. And what was I going to say?
Talking about Medicare, including the drugs.
Oh, Medicare, including the drugs. So it used to be, we had a lot of patients that would get on disability right away for being HIV positive. And so, after 2 years of disability, they qualify for Medicaid. The problem is that now, because of the medications and because we are keeping people healthier longer, they don't qualify for Social Security disability. And so I think some of them kind of go into this thinking, well, I'll just get on Social Security, but that's not it anymore. They usually qualify for some other health reason or mental health reason. But we don't see that number of on disability on Medicare. It's mostly our aging population. And sometimes once they hit getting close to 65, it's really working with our care coordinators to make sure that they do realize that the person could qualify for Medicare. We have a lot of Medicaid, Medicare co-infection patient or co-coverage on our patients. And the thing is those patients can still get the Ryan White services of transportation, some eye and dental. They can also get some of the other services that are offered through the various sites for them as well.
So as you know, Chris, we work with people on Medicare of all ages. It sounds like if you're a person with HIV or AIDS, you're hopefully connected with a local service provider that specializes in people with those health conditions. And if not, we need to find out who is so we can refer people so they can get not just SHIP services, but connections to additional information.
So the problem is in a lot of the rural areas of the state, there aren't a lot of HIV providers. There is Evansville has a big care coordination site. They don't do a lot of they have a clinic there. There's also Bloomington has a site. They don't do a lot of care in their clinic, but they do have the care coordination services, and they hook up people with providers that they know do HIV. So I know South Bend, Fort Wayne, Gary, all do. So a lot of our patients, unfortunately, that live in rural areas will actually travel to one of the, I don't want to say bigger cities. Part of that is because if they go to their local doctor, they know everybody in town, and they don't want people knowing their status. So a lot of times we do have patients that travel quite a distance in order to get their care. The thing is with Ryan White services, there's a statewide, that's what we call Ryan White Part A services. So that's statewide, and that offers care coordination services as well as some medical services. Now, the medical services through what they call the ADAP or AIDS Drug Assistance Program, they have a certain formulary that they use. So not all medications are on all HIV medications, but not all medications are on the formulary. So as a provider, sometimes it can get a little tricky. There are Part B services are throughout the state. Part A services are through certain what we call treatment group areas, Marion County and the surrounding counties, Brown County, and there's another county, I think Putnam County. Those counties, what they found is that they had over 1 million cases at one point in time, which allowed them to apply, or for the state to apply for these funds. So there's Part A, Part B, there's Part C. Those are services. A lot of clinics, like freestanding clinics, are Part C. Damien Center in Indianapolis, I think there's one up in Gary, is a Part C clinic. There's several of those. And those are the 3 main parts of Ryan White that provide care coordination and care services that pay for. For instance, when we have a patient that comes in, we like to get what we call baseline labs, and that's, checking their viral load, CD4 count. We check to see if they have hepatitis A, hepatitis B, hepatitis C, and we check a TB test. I mean, there's a lot of these baseline tests that we do, and to make sure that they're not co-infected, because that can affect some of our treatments. But I will say that the labs itself can run about $2,500 to $3,000 on that first visit. So it's not cheap, but then again, when you start looking at other medical conditions, I mean, healthcare is not cheap, but if they can get somebody that's going to pay for those services, we tend to work with them. And I mean, every day when we go into clinic, we go through our list and they'll be like, this person has Ryan White only. This person has no insurance. So if they don't have insurance, the care coordinators are talking to them. If they have Ryan White only, we know that we can only do certain things. The other thing is with Ryan White only is that we have to do as an HIV provider, we have to do their primary care. We can't even send them out to a primary care provider. So that's why we try, get them on Medicare, get them on Part, something so that we can send them to a primary care provider, just because we don't have a lot of times the capacity to do both.
So it sounds like that if you live in one of the larger cities in Indianapolis, you might find some really good comprehensive HIV and AIDS care, both medically and psychosocially. Mm-hmm. If you live in a rural county, then you're traveling. Mm-hmm. Okay. Yeah, that's unfortunately the state of other kinds of care. But when it's very specific like that, it just makes it harder. Megan, did you have any questions for Dr. Chris?
I do. Well, first of all, thank you, Dr. Chris, for coming on and talking to us about all this information. I learned a lot myself. Do you happen to have the number for the Ryan White Foundation?
So it's actually through the Indiana State Department of Health.
Okay.
Their HIV program. If you go under the Indiana State Department of Health and look up HIV services, it will show you. And it should also have a list of care coordination sites throughout the state that they fund for that. The Ryan White Part A is done more through the counties. And so like Marion County Health Department runs that one. And the the state might have listed the Part C programs as well. I will say, just because, I don't mean anything bad when I say this, but just because a physician is an infectious disease, or somebody is an infectious diseases provider, does not mean that they have a lot of experience in HIV. And so that's one thing, if looking for a provider, to make sure that they do. There are some primary care providers that have more experience than some of the infectious diseases providers.
That's good to know. Thank you. I'll look that website up, and I'll put that information in our chat box for the audience.
Mhm.
Can someone who lives in a rural county come to Eskenazi regardless of where they live?
Yeah, so if they have Medicaid or some kind of coverage, Medicare, whatever, yes, they can. Depending on the county, they may not be covered for Ryan White services because they have to reside in Marion County and the donut counties, as well as those other counties that I talked about. But yeah, they are more than welcome as long as they have coverage. They're more than welcome to come. We have a nurse practitioner that moved up from Bloomington. She worked at a practice in Bloomington, and a lot of patients followed her. So we have a lot of people that live in Bloomington, that live in Brown County. We have a lot of people that live in Hamilton County, because there's not a lot of HIV providers up there. So we really get a lot from the surrounding counties. I've got patients from Columbus that come up. So yeah.
Well, that's nice. I always think of Eskenazi as the Marion County Hospital, but it's nice that we can extend ourselves to people who don't have those services.
Yeah, and it's, I mean, they have to live within Marion County to get I think it's now Eskenazi Health Advantage or whatever they're calling it now. And within the surrounding counties for the Ryan White services. But we do have medical case managers that are not, that will work with patients that are not within what we call the TGA, or that don't qualify for Ryan White services, because we have a lot of patients who are over income for Ryan White services. So if they have something that comes up, we have medical case managers that can work with them and help them with whatever their needs are.
Okay. Megan, do you have other questions?
I do not.
Looks like you're checking your phone. Is somebody texting you a question in?
No, I was
Okay.
putting in the link for the Department of Health.
Okay. So if you do have questions, you can, maybe you're viewing this on our YouTube channel. We will funnel those to Dr. Chris to get you answers and post them on our Facebook page as well at a later date. So, you can always interact with us and we will respond. And probably in a few hours or maybe tomorrow, we'll put this up on our YouTube channel. So find us there and share this with people who might be interested. And we appreciate everybody coming today. Megan, what else do you have for us?
Well, I think we're ready to talk about what we have going on in July. So in July, we have some great sessions coming up. We're going to talk about Medicare's covered home health services. So what care you can get and cannot get under Medicare at home. We're going to talk about veterans and Medicare. That's going to be a great informative presentation because some veterans need Medicare and some don't, depending on their VA benefits and their health needs. And then at the end of the month, we are going to have a special guest, a friend of mine, Jessica Bamber, and we're going to talk about caregiver burnout. A wonderful topic. So with that, Susan, I think we are ready to rave goodbye.
Okay, and I'd just like to thank Chris for coming on this morning, and it's nice to see you in person and be able to present with you. We'll put our heads together here. We're good friends, so we can do that. And everybody have a terrific Monday and happy Juneteenth. Try to participate in something that's going on in your community to recognize today's the importance of today.
Yes, yes. Bye, everyone.